Hi, good evening, everyone. My name is Maria Chidi Lopez, and I have the pleasure today of kicking on the ECI case conference just 1 week previous to our annual meeting for CIS. Today's first case will be presented by Alexandra Greer. She is currently a fellow at PGY5 at the Allergy and Immunology Division of the Children's Hospital of Philadelphia. And we have the luck today to can with her senior mentor, Dr. Jennifer Heimel, who is the program director of the Allergy and Immunology Fellowship at the Children's Hospital of Philadelphia. And she has come prepared today to speak a little bit about the time is right, hematopoietic stem cell transplantation for invert error of immunity with a widespread infection. Alexandra, please take it away.
Thank you so much. As Dr. Titi Lopez said, I'm Alexandra. I'm a fellow at CHOP, and I'd like to thank the CIS ECI Organizing Committee for allowing me to speak today. And I have no relevant financial disclosures. So our patient is a 19-month-old male who presented with swelling and erythema of his right fourth digit that had not responded to oral antibiotics. His past medical history includes sickle cell trait and G6PD deficiency, and at this point he was growing very well. After admission, an MRI was obtained that showed osteomyelitis. He underwent incision and drainage, and the cultures grew Serratia marcescens. As a note, I have a timeline at the bottom because this is a rather lengthy case, and the purple star indicates where we are in the course. So his initial workup included a CBC demonstrating leukocytosis. And then we were particularly struck by his extremely elevated inflammatory markers with an ESR above 130. In a male patient with Serratia and these very high inflammatory markers, we were concerned about CGD, and so continued his immunologic workup with a DHR, which, as you can see here, shows nearly absent NADPH oxidase activity consistent with CGD. He then underwent single gene sequencing of CYBB, NCF1 exon 2, and NCF2, and was found to have a pathogenic single base duplication in CYBB, leading to a frame shift and premature stop codon. And this confirmed the diagnosis of X-linked CGD. He was initially treated with IV cefepime and then converted to oral fluoroquinolones due to issues with access. He was initially started on ciprofloxacin, but then was switched to levofloxacin in discussion with infectious diseases and hematology because levofloxacin is thought to have a lower risk of causing hemolysis in G6PD, has very good coverage for Serratia, and was also more tolerable for the patient. So he completed 8 weeks of antibiotic therapy for the Serratia. He was also started on itraconazole for fungal prophylaxis for his CGD. His bacterial prophylaxis was initially covered by his Serratia treatment, but once he finished with the treatment, he continued on fluoroquinolones as his bacterial prophylaxis, since trimethoprim sulfamethoxazole is contraindicated in G6PD deficiency. So I want to pause here and kind of poll the audience on whether you would refer for stem cell transplant at this time and kind of what factors you would take into consideration. Just as a quick recap, the patient is now 20 months old. He's had one major infection that is now resolved and otherwise healthy. Then a preliminary donor search showed that he unfortunately has no matched related donors, and his mother is a carrier of the same CYBB variant.
I can see a question in the chat that I'm gonna address. But first, I wanted to give the audience an opportunity to answer the first query raised by Alexandra. So for this 20-month-old patient with a confirmed diagnosis of CGD, that has presented a major infection, but otherwise is healthy, no match-related donors, anyone in the audience, would you refer this patient for evaluation for a potential allogeneic hematopoietic stem cell transplantation procedure? Would you not consider that at this time? We're looking forward to gather some of your thoughts. So if anyone wants to go ahead. I think not everyone is maybe ready for BMT referral, but I do see a question. Oh, I do. Yes, I see Ben Solomon, and he said that I would probably refer at least for evaluation. The lack of related donor possible reduces the enthusiasm. And I hardly agree with Ben that at least it's worthy for referral for evaluation for any potential definitive therapies for this Imber era of immunity. I do have another question, Alexandra, that is raised by Dr. Abraham. And I would say, was there any evidence of somatic reversion in the small population with low NADPH oxidase activities? Um, do you want to address that?
Yeah, I don't believe that we specifically looked for that at the time.
Okay.
That, yeah, that would be true.
Okay, wonderful. I think that will probably be addressed in future iterations. So then take it away. Let us know what happened next.
Okay, so we did refer to our BMT team. Um, they thought that he was a good candidate for transplant and initially planned for allogeneic stem cell transplant for the following spring, kind of after viral season. But by that point, he was doing really well on prophylaxis, and so family decided to wait. He then presented a year later with multiple lesions in his liver, chest, abdomen, brain, and back, as you can see here. Biopsy from the mass on his back, which is shown on the right side of the screen, grew Aspergillus fumigatus. He was treated with voriconazole and prednisone. He demonstrated gradual improvement over a period of about 4 to 6 months. You can see on the brain MRI here. After that, his steroids were gradually weaned, but he remained on treatment dose voriconazole. After about a year of stability, he was again found to have new lesions, this time in his liver and lungs. There was quite a bit of discussion around biopsy to determine whether this was still the Aspergillus or a new pathogen, but ultimately the biopsy was not done, and he was followed with serial imaging. These new lesions demonstrated interval improvement with no change in treatment, so he was just continued to be monitored. However, early the following year, surveillance MRI demonstrated that his brain lesions had worsened, as you can see here. Again, biopsy was not able to be completed. So his voriconazole dose was increased and he was continued to be followed with serial imaging. After 3 months, his imaging was really unchanged. And at the same time, he developed a widespread erythematous rash that we attributed to the voriconazole. So he was switched to posaconazole. And then his imaging gradually improved. This MRI was a year after he started the posaconazole. And although the lesions are still visible, they're certainly improved. During this year, he was referred to the NIH for discussion of gene therapy or high-risk stem cell transplant due to his active fungal infections. But the logistics were really not feasible for the family, so he continued to be followed at CHOP. He was then stable for several months, but then developed a new manifestation of his disease. with cutaneous papular lesions on his trunk, arms, legs, genitals, and face. After biopsies, viral testing, and cultures, the lesions were determined to be granulomatous and not infectious. So he was treated with topical steroids and oral azithromycin to provide additional anti-inflammatory benefits. The lesions did improve, but kind of continued to flare intermittently. So at this point, we again came back to discussion of stem cell transplant as a definitive therapy, given that medical management was somewhat controlling his symptoms, but had not completely resolved them. And so again, here's a brief summary of kind of where we are in the case. The patient is now 6. His prior serratia osteo is completely resolved, but he has this ongoing multifocal aspergillus infection, the new inflammatory skin lesions, but otherwise his performance score is very good. And then as before, he still does not have any match-related donors.
So what we're trying to get from the audience is if there's more enthusiasm now that he has,
Or less.
that he has an invasive fungal infection, and that we were lucky to recover a bug for it. I do have a question that says, what is his growth like? Alexandra, you want to address that?
Yeah, his growth is actually still pretty good.
So it seems that no failure to thrive for our
Right.
little fellow with 6
Yeah.
years old.
Yeah, no failure to
CDD,
thrive, and he hasn't had any GI manifestations.
no colitis or so on. So anyone wants to share with the group about willingness to consider potentially definitive therapies for these patients, such as allogeneic stem cell transplantation, or now that the patient has a multifocal aspergillus infection, is this a turn down to consider potentially definitive therapies? Maybe. So I believe we're not gathering, a pulse here, but I do. Oh,
right.
yes, we do. So we do have, oh, wonderful. So on the one hand, the patient has demonstrated more severe sequela of a CGD diagnosis that makes an HCT more pressing, given that he's likely to continue experiencing this in the future. I completely agree with Dr. Solomon here. But on the other hand, active infections makes the transplant more tricky. And how tricky? Not sure what the right answer is, probably shared decision making. So I think Dr. Solomon is raising pros and cons. So Alexandra, why don't you take us to what were the considerations at that time and the process that allow us to reach to a best next step at this point?
Yeah, and I think you hit exactly on the dilemma here. You know, it seems like well, we know that with medical management, we aren't able to completely control his disease. You know, there's a concern that the longer we wait, the more sequela are going to develop. But then we also know that transplanting with active fungal infections or with active infection in general is certainly dangerous. And so that was really what the discussion came down to, both within our team and then also with the family. So I'm going to go through kind of some of the data that was considered kind of in making this decision.
Alexandra, I do have another comment in the chat. There is someone that says, I think, Dr. Kalashnikova. I'm sorry if I misspell your last name, but Tatiana here says, should we to treat aspergillus and then to transplant? So maybe she is tilting more into medical management first, trying to address the multifocal Aspergillus infections and then proceeding to transplant.
Yeah, and I think that would be kind of our best case scenario. Um, you know, Unfortunately, at this point, we've been trying to treat the Aspergillus for about 4 years and have never been able to completely resolve it. Okay, so to kind of go into some of the data that was considered. So historically, uncontrolled fungal infection was a relative contraindication for stem cell transplant, and intracranial fungal infection, like we have here, was an absolute contraindication at many centers. However, over the past decade or so, data has emerged that at least in certain populations, it may be possible to safely transplant patients with invasive fungal infections. So here I'm showing data from 2 different studies of HSCT in patients with invasive fungal infections, or IFI. On the left, this retrospective study by Rota et al. From the Netherlands includes pediatric patients with invasive fungal infection undergoing stem cell transplant for any indication, and demonstrated 78% survival at 1 year. And importantly, none of the deaths were attributed to the pre-existing fungal infection. In this study, about 25% of the patients had intracranial lesions. But as promising as this study is, there were some limitations in that they only had 23 patients with invasive fungal infections, and they were only followed for a year. Another retrospective study shown on the right here by Maziarz et al. Out of the CIBMTR had many more patients and had at least 5 years of follow-up. Now, clearly, the overall survival here of the patients, both with and without IFI, is quite poor. This study was both pediatrics and adult patients and was limited to oncology patients who had not responded to first-line therapy. In this study, the patients with pre-existing invasive fungal infections had about a 15% lower overall survival, though the deaths were predominantly attributed to progression of their underlying cancer rather than recurrence of their fungal infection. So the authors here conclude that in patients without another option, invasive fungal infection should not preclude stem cell transplantation. After this data came out, additional studies were done specifically in CGD patients. The top 2 graphs are from a study by Dr. Leiding and the Primary Immune Deficiency Treatment Consortium and show no effect on event-free survival with active or resolved infection or controlled or uncontrolled inflammatory disease. However, it is important to note that none of these patients had intracranial infections. The bottom table from Chiesa et al. From the Inborn Errors Working Party, the EBMT, similarly shows that presence of infection did not significantly affect overall survival or event-free survival at 3 years. This study did include all infections, not just IFI, and whether there was intracranial involvement was not specified. But taken together, these studies show that stem cell transplant may be safe and effective for CGD patients with invasive fungal infections. And then lastly, a third study that was just published this year by Klein et al. Out of the NIH shows the same overall conclusion, with 70% of CGD patients with invasive fungal infection who underwent transplant surviving. However, it's important to note that only 3 of the patients had intracranial infections, and unfortunately, all 3 of them did pass away. 2 of the deaths were attributed directly to the fungal infection. So back to our question of transplant for this patient. So again, here's kind of the summary of his clinical course, and then to go over what we just discussed. So invasive fungal infection prior to stem cell transplant modestly decreases overall survival in oncologic patients and all comers. But in CGD patients specifically, prior infection or inflammation status does not affect overall survival. However, the data on intracranial infections are limited, and in the NIH study, 100% of the patients with intracranial infection passed away.
Alexandra, I just want to share with you some of the comments we are getting now, sparking the discussion in the chat. We have Dr. Kaviani saying, the way I think about this transplant for the transplant for these patients, the only way to cure them of their infection is a new immune system. And it is not uncommon to take these patients with active infections. We also have another comment by Dr. Harville. We had success by keeping antifungal going, include antibacterial, weekly IVIG, and match hematopoietic cell therapy. I failed to mention we apheresis the parents and also infuse irradiated neutrophils each day. So granulocyte infusions, which has been described also as a bridge for potentially definitive therapies. So I think these are some of the comments from our audience. And I think that it's important that now accounting that some of the attendees feel strongly about going to transplant for this patient, what happened next. Take us about the journey for the patient now.
Yeah. And that is ultimately what we decided as well. We referred the patient back to our BMT team since his infection seemed to be stable to improving. And like people said, really the only way to actually eradicate the infection was to give him a new immune system. So he received an infusion of TCR alpha beta and CD19 depleted peripheral blood stem cells from an unrelated mismatched 9 out of 10 donor after a conditioning regimen consisting of busulfan, fludarabine, cyclophosphamide, and ATG. He received mycophenolate for GVHD prophylaxis in addition to the T cell depletion of his graft. And then he also was given 1 dose of rituximab due to a history of EBV viremia. His inflammatory skin lesions initially resolved during conditioning, but then it returned after he engrafted. A brain MRI was obtained at the time of engraftment and demonstrated worsening of the parietal lobe lesion and surrounding inflammation and edema. Although this was thought to be due to an influx of healthy neutrophils post-transplant, amphotericin was briefly added to cover for infection. He had repeat scans 1 week later that were stable, and the amphotericin was discontinued at this time. So 17 days after transplant, he had a DHR that showed 79% of neutrophils with an intact oxidative burst. And then by day 26, his DHR was normal, and he demonstrated 100% myeloid chimerism. He was able to go home after about a month. And then his most recent labs at day 60 still demonstrate 100% myeloid engraftment and a normal DHR. He underwent repeat brain MRI at day plus 60, which showed a stable lesion with marked improvement of the surrounding inflammation and edema. And his chest CT also demonstrated improvement. So in conclusion, I think treatment of patients with CGD and invasive fungal infection, particularly intracranially, requires careful decision-making, weighing significant risks for each option. You kind of tipping the decision towards medical management is that there is not a lot of data on the impact of intracranial fungal infections in CGD patients undergoing stem cell transplant. And in some centers, active intracranial infections are contraindication. On the other hand, as we've discussed here, stem cell transplant may be the only way to eradicate the infection. It also can resolve inflammatory manifestations of CGD and prevent future infections. The takeaway I have from the data we discussed here is that pre-existing invasive fungal infection does not significantly impact the overall survival of patients undergoing stem cell transplant. So I think I have kind of three main takeaways that or things that I learned from this case. One is transplant early. The longer definitive therapy is delayed, the greater chance of an infection or other complication occurring that will in turn make the transplant more dangerous. I think this patient would have been in a much different place for transplant if we had gone to transplant after the initial Serratia infection and before any of the Aspergillus happened. And then I think secondly, there's usually not going to be a perfect time for definitive therapy. And while infection status definitely has to be considered as part of the transplant eval, active infection should not kind of automatically preclude someone from undergoing definitive therapy. And then, as this patient demonstrates, patients with CGD and active fungal infections, even intracranial ones, can be successfully transplanted. And although we are still early in his course, only 2 months out, he is doing quite well. And with that, I'd love to take any questions and hear Dr. Heimel's thoughts.
Yeah, so we already have a couple of comments I want to make sure we have an opportunity to address. One was to ensure that you can show the repeated DHR after assessing the chimerism that you did. And then, so that one is addressed. The other one was, I know this wouldn't be typical, but in relation to the recurrent skin granulomas, has anyone ever assessed a skin-specific myeloid chimerism in CGD for things like resident macrophages that may be more resilient to the hematopoietic stem cell therapy conditioning? I don't know, Alexandra, if you want to take, a first take, or you want to handle the question to your senior mentor.
Yeah. I'm not aware of any data looking at that, and it's certainly not something that we have done. Dr. Heimel, do you have any?
I'm not aware of any data on the feasibility, even to kind of isolate functional neutrophils from the skin and then do a functional assay. I think that I personally think that would probably be fairly technically challenging to do, given kind of the fragility of neutrophils and their lack of time stability as well. But I think Roshni put a lovely comment in the chat that I think is quite helpful for everyone to hear. So, she mentions that you could assess blood monocytes with a DHR using PMA and FMAT-LuFi to show the DHR in other myeloid cells. And maybe, Roshni, I don't know if you want to jump in here because you certainly know this better than I do. This is your data. But I assume you're saying that could be a proxy then for the skin, maybe?
I mean, if Ben's question really relates to looking at other myeloid cells, because Jen makes a good point, to culture from skin the macrophages and then stimulate would be a bit tricky, but you could use blood monocytes as a surrogate for cells in the other myeloid compartment. You have to keep in mind the magnitude of NADPH oxidase activity to PMA in monocytes is, at least 2 to 5 folds lower than neutrophils. So you have to be careful in the interpretation, but that definitely can be done far more easily if that was your original intent, to look at other myeloid cells beyond the neutrophil compartment. One could also look at ROS activity, besides DHR, if you're concerned about particular types of infections, because there can be some spectrum in the hypomorphic or patients with somatic reversion compared to the null variant patients. And so we typically use a combination of DHR, NADPH oxidase specific proteins, and ROS, because we sometimes see variations between these functional assays depending on the type of mutation and the gene involved.
We are very, very thankful for Dr. Roshini Abrams for their insight into how to understand the phenotype and potential phenotype correction beyond the neutrophil compartment, and also to understand what is the role of ROS testing and to characterizing genotype and phenotype for CGD patients. So overall, very thankful. I don't know if anyone else has a final comment.
I actually do. I do just want to comment, though, that anything we do on the blood may be different than what you would see at a tissue level, because the tissue eradication of the resident macrophages, which I think may be what Ben is getting at, may not be as complete with conditioning regimens, particularly we use busulfan at a reduced toxicity dosing. And so you may not, what you're getting in your blood may not be exactly the same as what's in the tissue, and what you get in the blood wouldn't be the same as necessarily what you get from a marrow. But what we do as standard of care in transplant after transplant for an inborn error of immunity does not include looking in marrow, because we're not looking for small amounts of residual disease. In general, we think that in CGD, as long as we're seeing at least 20% correction, we're good, right? You see a 20% DHR, 20% myeloid chimerism, save the day, we're happy. So I think that Ben does bring up a really interesting point that I don't think we quite yet have the technology to be able to answer that specific question. And I also want to point out that what was particularly tricky about this patient is that there were no well-matched donors. So this was a mismatched, unrelated donor who did get a manipulated graft. And so there was some delay to the T cell reconstitution as well. And that also, even though T cells are not necessarily thought to be as important in Aspergillus control, we certainly can see Aspergillus in infections in the setting of T cell dysfunction. And so we were worried that by now wiping out what might be his last defense against containing this CNS Aspergillus infection, we were really going to allow it to expand. So the immune reconstitution syndrome that we saw in his brain, we think was probably a combination of both the neutrophils it was just neutrophils, but was not any T cells because he had been T cell depleted. So this wasn't a peripheral expansion of any T cells that came along from the ride.
And we certainly appreciate this further insight about, what was the thinking process about the immune reconstitution, and how did you make the decision to discontinue amphotericin and follow the patient. But out of respect of our next presentation, I would like to transition and invite everyone to continue talking in the annual meeting. Thanks.
Very good. Thank you. It was a wonderful case. Thank you so much for everyone who participated. And now I'm going to share my screen with you guys. Very good. So before we go ahead, can you all see the screen?
It's not in presentation.
Oh, let me see. See, how about now? Oh, same thing?
Yes, it's the same thing.
Can you flip do you have two screens? Can you flip your screens?
I think I can do this. There you go. Let me actually, I'm going to unplug my other screen in that way. How about now?
It's not in a presentation mode, Juanita. Can you try again clicking on that button down low right? Yeah. Now that's good.
You can see it. Perfect. Okay. Very good. So thank you so much for the previous case, and I want to introduce this new case is being presented by Priyal Upadhyay, who's a second-year fellow at LSU Shreveport. And the senior mentor for this case is Dr. Roshini, who has kindly, Roshini Abraham, who has kindly helped us immensely with this case because part of the final workup for the case was actually performed by her. So we really, really appreciate all the help that you've provided, Dr. Abraham. So without further ado, Priyal, I'll let you start presenting.
Thank you so much, Dr. Valdez. Hi, everybody. I'm Priyal. I'm going to go ahead and start presenting our case. So our case is a 9-year-old established patient who has been following in our allergy clinic who presents for a rash. We've been seeing her in clinic for the past 3 years for symptoms of eosinophilia, atopic dermatitis, eosinophilic colitis, and multiple food allergies. She also has a history of growth hormone deficiency, abnormal microsomal array, which was done previously at Texas Children's, and she had seen a geneticist for it, but it was not known to cause any significant findings when the workup was done, Hashimoto's thyroiditis, and failure to thrive. Previously, when we saw her in clinic, her eczema was very well controlled with topical steroids. And for this patient, her family history was significant for no consanguinity. She did have other siblings that had a history of atopy with atopic dermatitis, asthma, and food allergy, but again, the parents were not related in any way. So initially, she presented with this rash in October of 2024. She was treated for tinea, and we obtained a parasitic workup, which was completely negative. We then saw her again in December of 2024, and at this point, we considered a broader differential. We looked at if this was psoriasis, granuloma annulare, or what was going on with this eczema. I apologize. I'm not sure why the light is blinking. Let me just turn that off. My apologies. And so at this point, we considered a broader differential for what is going on with this rash. So we decided to obtain a skin biopsy. The results of this biopsy were consistent with atopic dermatitis, but the clinical picture was concerning given that the appearance of the rash was just atypical for eczema and it was refractory to treatment. So we did an internal referral to immunology and obtained an initial immune workup, which was significant for normal immunoglobulins. Her CBC was normal. Her IgE was actually 98, which was unusual given how severe her eczema was. And she had a normal response to vaccines. Just to go back to her GI history, she has this history of failure to thrive and recurrent abdominal pain. In 2023, she was admitted to an outside hospital for recurrent abdominal pain. At that time, an endoscopy was done that showed eosinophilic colitis, and during that admission, the patient was unable to tolerate any oral intake and a G-tube was placed. Over time, within a year, her oral intake improved and the G-tube was removed by a different gastroenterologist. She still has recurrent abdominal pain, but there is no definitive diagnosis as to what is causing her abdominal pain, and her repeat endoscopy was not completed. And as you can see here, for her growth chart, she does have significant failure to thrive that's been present from birth, and even her height chart shows her growth stature deficiency. After doing the initial workup that showed normal immunoglobulins, we decided to obtain a lymphocyte subset panel. As you can see here highlighted in red, her absolute CD3 count was normal, but we sent lymphocyte proliferation to mitogens and antigens, and as you can see on the right, they were both decreased. Given that there was abnormal proliferation to both antigens and mitogens, we ordered proliferation stimulated by anti-CD3 antibodies, and anti-CD28, which you can see at the table above, were all also decreased. And we then obtained testing to quantify T regulatory cells, and they were all decreased as well. And finally, despite the normal immunoglobulins that we had seen in our previous workup, we wanted to make sure that the B cell development was normal. As you see here, there's the total number of B cells is normal, but there is a decreased number of total memory B cells and class-switched memory B cells.
So at this point, we would like to invite everybody to chime in. What do you have and what would you have in your differential with a case like this? You have predominant atopy, not so much of an infectious history at this point, but there is a GI involvement. What can you consider with this potential combined immune deficiency? Because we know there's, at this point, both T and B cell lines are affected with predominant atopy. So if you want to share in the chat, what are your thoughts before we share what our differential was for this case? Okay, so Harry is saying DOCK8 deficiency. Okay, great idea. What else could be considered? I believe that TGF-beta defects have been associated with EJIDs. Great. Then Dr. Kalashnikova, STAT5 deficiency. Great. All of these are fantastic options. And STAT5 deficiency as well, which could also connect to the low Tregs. Awesome. IPEX. Fabulous. Thank you so much for your participation, because we basically considered many of these, and we were initially thinking predominantly on the combined immune deficiency with atopy. So I'm going to share some of the other differentials that we considered. So you can continue, Priya.
And so, just as Dr. Valdez mentioned, considering her ATP and eosinophilia with the normal IgE, we looked at several differentials to consider, and this is why we decided to proceed with genetic testing to narrow down what was going on with the patient. And the results of her genetic testing were significant for CARMEL2 deficiency. I do want to reemphasize again that there was no consanguinity present in the family at all.
Perfect. So we're gonna transfer to Dr. Abraham, who has kindly put together a fantastic review, and she's gonna help us understand a little better what this CARMEL2 deficiency entails, and then we'll go back to Priya.
Do you want to just bring up the rest of the slide? So I was just said for the trainees, to look at the genetic testing report and sort of break it down into relevant information, looking at, the particular isoform, because that's important. There are 3 isoforms for CARMEL2, but only isoform 3 is functionally relevant in human leukocytes. So you have to make sure that you're using that isoform for your variant nomenclature, etc. Important point to note, it's homozygous. And of course, in OMIM associated with CARMEL2 deficiency, it's also called immunodeficiency 58. Hopefully we'll get away from that sort of nomenclature and go to those dyadic terms. And I did some variant analysis and consistent with what the INVITI report showed. It's pathogenic. The ACMG score is 10. And because it causes a frame shift, it's got a PVS1 classification and a PM2. So bottom line, it is a pathogenic variant, which is biallelic. So fairly straightforward there. Then next slide. I'll turn it back to Juanita or Priya.
Thank you so much, Dr. Abraham. So just going over the basics of T cell activation, we know that we have 2 signal there's a two-signal model of T cell activation. So the first signal is the TCR recognition that happens when the antigen binds to the MHC. The second signal comes from the CD28 co-stimulator on T cells binding to ligands, the CD80 or 86, on the antigen-presenting cell. And you need these two keys to kind of turn the lock and activate the T cells. So once the T cell is activated, TCR and CD28 trigger the association of the cytosolic adapter, which is made of CARD11, BCL10, and the MALT1 complex, which then stimulates NF-kappa B signaling. The role of CARMEL2, as we can see here, is that it is an essential scaffolding protein that is very important for CD28 co-stimulation. And it plays a role in the production of, if this is defective, it leads to impaired T cell activation, differentiation, and function, which I'm going to turn back over to Dr. Abraham to go over in further detail.
Okay. So Juanita and Priel sent this testing out that they already briefly showed you in an earlier slide, but this is just a pictorial representation of that data. And you can see the healthy controls at the bottom. And if you look at proliferating cells, you know, these are lymphocytes, but they sit high up because they're proliferating. They look almost like blasts, and you don't see that in the patient. And then if you zoom in on the T cell compartment and you look at T cell proliferation in response to anti-CD3 plus anti-CD28 cross-linking, you see good response in the healthy control and you see none. And this is looking at a marker for T cell activation, CD69. Again, you can see that the healthy control has that and the patient doesn't. Now, if you stimulate the patient T cells with IL-2, so anti-CD3 plus IL-2, you do rescue some proliferation. You can see that there's a partial response here. It's not fully normal, but there is some response in contrast to when you go with the anti-CD3, anti-CD28 cross-linking for the reasons that Priel alluded to in this slide previously. And this is known with CARMEL2 deficiency, that there is failure of T cell activation proliferation, particularly in response to CD3 and 28 cross-linking. Next slide. Just a reminder of the protein structure of CARMEL2. Depending on the isoform you look at, it's between 38 to 39 exons, but we said for numbering purposes, we go with isoform 3. And so this patient's mutation is actually really in the N-terminus, even before the plextrin homology domain. So it really would wipe out everything downstream. So you'd really get a robust loss of function phenotype with where the mutation is located. Next slide. And so I looked at CARMEL2 protein expression in T and B cells, healthy control on top, patient at the bottom, and you can see that there's essentially no CARMEL2 protein expression, which is what we would expect based on where the mutation is located. Next slide. Okay, do you want me to do it or you guys want to do it? Priel, want to do it?
I'm happy to do it.
Go ahead.
The functions of the CARMEL2 in the immune system, it works for actin dynamics and cell migration. It plays a role in T cell migration and adhesion. It plays a role in CD28 mediated co-stimulation in T cells. It plays a role in NK cell cytotoxicity. And as we discussed previously, NF-kappa B signaling pathway regulation, it has a very big role in that, in T cell polarity and immune synapse formation. And in mouse models, we see defects in T regulatory development as well. So overall, it plays a very big role in several aspects of the immune system.
I would just add over here that even in the human patients who've been studied have low Tregs, as you saw in this particular patient, they also have increased naive T cells, lower memory T cells because of that differentiation defect, and their NF-kappa B signaling pathways in the canonical pathway, not the non-canonical pathway. When you think back to the cartoon that Priel showed you earlier. So yes, multiple components. So some of the papers, if you go to the next slide, some of the papers have looked both a Treg quantitation, but also surrogates for Treg function, looking at CTLA4 expression, both basal and after stimulation with anti-CD3 and anti-CD28. So this is just reminding you that of Treg quantitation using FOXP3 and how Tregs express CTLA4 constitutively in contrast to effector T cells. So next slide. This is a assay that looks at CTLA4 upregulation after Treg activation. And way over here on the right, the top right over there, that's some data from Bodo Grimbacher and his group, where they used it for CTLA4 haploinsufficiency, LRBA deficiency patients. The data on the left side is data from my lab, looking at the same thing, looking at CTLA4 upregulation in FOXP3 positive Tregs after activation. Next slide. And so this is just an example, showing an example. Here it's a healthy control, and the patient here happens to be a CTLA4 haploinsufficient patient, but just to show you an example. And then next slide is the data from their patient, from the patient that with the CARMEL2 deficiency, healthy control on top, the patient down at the bottom. And then over to the right bottom, I just put in some data from another paper where they looked at a cohort of 15 CARMEL2 deficiency patients, and they looked at CTLA4 upregulation, basal and post-stimulation, and the patient, the red dashed line is the unstimulated, and the red solid line is the patient post stimulation, showing very little CTLA4 expression. And then they made a graph out of the data of the 10 patients they assessed that way to show that there's very little CTLA4 upregulation relative to what they see in the healthy controls. I did want to make a point on the next slide, is that there's considerable variability in CTLA4 upregulation in activated Tregs. So you have to be a bit cautious in interpreting the data. And so it's good to have, as many healthy controls to get a sense of that variability. So this is about 87 healthy controls, and you can see there's quite the spread. And so if you look at the patient, sure, she's low, but she falls within the 5th percentile of the healthy cohort. So sometimes you have to be careful. If you do just a few healthy controls, depending on where they fall, you might say, oh, this is terribly abnormal. Or if you do many more and you get to see the real spectrum of CTLA4 upregulation and Treg activation, then you have a bit more of a nuanced interpretation of those results. But nonetheless, CARMEL2 has been shown to be important for Treg developments in follicular T helper cell development. So not terribly surprising. And certainly they see that quantitatively, as they showed you earlier.
So going back to our clinical manifestations of this CARMEL2 deficiency that we saw in our patient and things that we didn't see. So these patients often have recurrent infections. These can be respiratory, bacterial, fungal, viral infections, as well as GI tract infections. Skin manifestations are very common, similar to what we saw in our patient. It presented as a psoriatic rash versus eczematous dermatitis. You can also see warts, solar urticaria, spongiotic dermatitis. There's a wide array of symptoms that can present clinically. And these patients also are associated with EBV smooth muscle tumors. It is actually one of the things that leads to the mortality in these patients, typically in teenage years. So this is very common. And GI manifestations can come up as inflammatory bowel disease, lymphocytic esophagitis, Crohn's, dysphagia, and failure to thrive. And the image you see below shows how variable the clinical features are and manifestations are, and what percentage of patients can present with these. And the next slide again goes through the variety of defects that we can see in these patients. And I'm going to turn it over to Dr. Abrahams to go into detail, but I did want to point out that CD28 defects versus CARMEL2 defects, the reason we see more deficiencies in CARMEL2 is because, and the widespread array of symptoms is because of the important role it plays as a scaffolding protein in so many of these features.
There are a couple great questions in the chat before we switch back. One
Oh, yes.
is Ben that is asking about the parental genotypes. Do you want to?
Absolutely. So the parental genotypes, we don't have them yet. We are working on obtaining them. The parents are actually recently divorced, and they have 9 children, so it's a little bit of a tenuous situation, but we are working on obtaining those.
And the second question is, what is the driver for atopic manifestations in CARMEL2 deficiency? And they're asking, is it abnormal? Is it the abnormal T cell activation leading to Th2 skewing, or the abnormal Treg function, or both?
So from my understanding, the Th2, there is redundancy in the Th2 pathway. So the CARMEL2 deficiency actually doesn't cause any change in the Th2 pathway, and it doesn't inhibit it. So we do see inflammation and atopic dermatitis for that reason. I hope that answers your question.
But it also skews the diversity of the T cell repertoire. And so it's quite possible now in this patient, there's a bit of a paradox because you didn't see the elevated IgE that you would see if there was a Th2 bias. And I think it would really be worth doing, which one can do with intracellular flow cytometry, looking at Th1 versus Th2 polarization to see whether the skewed T cell repertoire could lead to a Th2 bias. But then it doesn't fully explain why this particular patient didn't have the elevated IgE but had the other atopic manifestations. Other studies seem to suggest that it is due to the impaired T cell function, but I think it would be a combination of both, because I think it's multifactorial in this case and not purely related to repertoire diversity itself.
Thank you. And just a few takeaway lessons from this case that we wanted to point out. So it's important to consider in an atypical patient like this, CARMEL2 deficiency, or really any immune deficiency. Typically when you see combined immune deficiency with atopy, so atopic dermatitis is seen in almost 70% of patients that are CARMEL2 deficient, and it presents typically in the first 2 years of life. Also considering it when you see very early onset IBD or IBD inflammatory GI disorders and recurrent polymicrobial infections with viral, bacterial, fungal, or mycobacterial infections. And again, to reemphasize the role of CARMEL2, it's important for CD28-mediated NF-kappa B activation in CD4 and CD8 T cells. It's essential for the development of memory CD4 and CD8 T cells, T regulatory cells, Th1, Th17, memory B cells, natural killer cells, and T follicular helper cells. And we just talked about this previously, but the redundancy in the Th2 lineage is important to point out. The redundancy is why they don't rely on the CARMEL2 to survive, and that's why it can survive. The next slide. So just takeaway lessons for the diagnostic workup, kind of beyond the antigen and mitogen proliferation. It's important to obtain the anti-CD3, anti-CD28 proliferation. Also very important to take a look at the naive and memory T cells and to differentiate the type of cells that we're looking at, naive T cells, TEMRA, and central and memory effector T cells. And this can be done by looking at markers such as CD62L, CCR7, and or CD27. It's also important to take a look at Treg quantification and CTLA4 expression, defect in CTLA4 expression in basal and stimulated Tregs, and also at the CARMEL2 protein expression itself. And in these patients, it's important for monitoring. So infectious risk, as we mentioned, EBV and associated smooth muscle tumors are very common and the highest risk for mortality. They did mention that full body screening is something to be considered. In our patient, she is EBV and CMV negative. We currently have not obtained full body imaging, but that's something that we are considering in the future. And therapy, stem cell transplant is the main therapy available. We have started discussing this with our patient, but it's an ongoing discussion. And finally, Dupixent for the attenuation of the Th2 inflammation. So in our patient, actually, her atopic dermatitis resolved. Currently, she does not have this rash. Her skin looks completely normal. And it's something that we are considering in the future should this occur again. Not so much for treatment of the cause of it, but more to see if that'll help the Th2 inflammation. And with that,
Clearly, we just want to add that somatic reversion has been reported in CARMEL-2, and so the patients with somatic reversion, they do have increased differentiation into T follicular, Tregs, etc. So that has been reported with this particular disorder. We've had a couple of patients with EBV, smooth muscle tumors, and we did attempt transplant, but unfortunately, I think the child became too far gone in the process, so that didn't work out. His younger sibling also had EBV, smooth muscle tumors, but because one child died in the family, the parents refused transplant for the second child. So we don't know whether that child is alive or not. But yeah, that's absolutely something to consider because it can be quite widespread and then rather challenging to manage. I think Terry is asking about CD5 positive B cells, and they did the clinical immune studies elsewhere, so I'm not aware if they've done that. Did you guys do that?
I don't believe we've done it.
Is there any particular reason, Terry, you were asking about looking at CD5 B1 B cells in this patient? I don't know if Terry is still there or he can hear me. Terry, if you can hear me as to the reasoning for looking at B1 B cells, if you don't mind popping it in the chat.
And Harry is also asking about reports of malignancy associated with CARMEL-2. So the main one that Priya already mentioned, but Dr. Hyman also is mentioning about lymphoma, which has been associated also with EBV.
Jen, I wasn't aware of gain of function in CARMEL-2, only loss of function.
I guess I can come off mute because I had been speaking before, so I'll use that luxury. It's easier than typing. But there was just a report, and I can put it in the link that I only because I have a clinic of severe atopic patients, so I had been doing a little bit of search, but I'll find it and put it into the chat.
Okay. Great. Okay, so Terry says that he asked about the B1 B cells because of their T independent. I'm assuming she got her normal vaccines before she came to you. Do you know if she responded to the polysaccharide vaccine?
Yes, she did. She responded to all of them.
Okay. So, one could argue that if she got the polysaccharide vaccine and responded, that is a T-independent antigen. But the class switching for pneumococcal polysaccharide is with B helper neutrophils and nothing to do with T cells, to get the IgG, IgA antibodies to pneumococcal. So, yeah, even in the global study that was published in 2021, 89 patients, I don't think we looked at B1 B cells that I'm aware of. So just giving Jen a moment to see if there's a CARMEL-2 gain of function. I wasn't aware.
I'm still searching for the article, but this is the link to the gene ID NL National Library of Medicine that had the comment about gain of function. I'm putting that in as I continue to search.
Super.
So you can never find what you want to find when you're put on this one.
That is true.
I think we're about to
Saying that there are some cases related to T-cell leukemia and lymphoma with Carmel-2 gain of function generally involves. However, it's not clear to me whether that's germline or somatic.
Oh, fair point. Okay.
That's a great
because sometimes we see somatic mutations in our genes of interest associated with the adult malignancy, hematological malignancies.
And that's more thematic. That's true.
But thank you so much for bringing that to our radar, because regardless, it's helpful to know that.
Right. Well, thank you so much. In the interest of time, because we're already past 8, we thank you for your help, for the fantastic presentations, and this has definitely awakened some interest in everybody. So thank you all for your time. Thank you for participating, for sharing your knowledge and your interest. And we hope to see you all at CIS, either in person or virtually, because it's just coming up next week. So thank you again. Have a wonderful evening. And I don't know if there's anything else.